Hello, everyone, and happy Malnutrition Awareness Week 2025. Thank you all for joining us for today's program titled Childhood Food Insecurity and the Critical Role of the Practicing Clinician. My name is Kelly Kinnear from Aspen, and today we are honored to be joined by Dr. Kimberly Montez. Dr. Montez is Associate Professor of Pediatrics and Social Sciences and Health Policy and Vice Chair of Social Impact in the Department of Pediatrics, Assistant Director of Research Access, CTSI Community Engagement Core at the Wake Forest University School of Medicine. She also serves as an Associate Editor for Pediatrics, the official journal of the American Academy of Pediatrics. And Dr. Montez has done extensive work with the AAP on the topic of food insecurity, so we are very excited for her to share her expertise with us today. So before we get started, I'd like to thank ByHeart for their support of today's program. And today's session will conclude with a question and answer period. You may submit your questions at any time using the Q&A function at the bottom of your webinar player. And now I would like to welcome Dr. Kimberly Montez. Thank you so much for joining us today.
Thank you so much for having me, Kelly. I'm so excited to be here with you.
Yes. So I would like to start our conversation today with just some definitions and descriptions. So what is the definition of food insecurity? How is it different from hunger? And what should we know about food insecurity?
Great. It's a topic that I'm very passionate about. I devote a lot of my research and my clinical care to all the social drivers, but in particular food insecurity. So hunger is actually a physical feeling of discomfort or weakness that comes with the lack of food. So you probably experience it yourself. Sometimes you may even be hangry. That is a thing. Whereas food insecurity is a household level economic and social condition of limited and uncertain access to nutritiously adequate food to live an active and healthy life. That is the official definition from the USDA. The USDA does measure it annually using the food security scale, and it is 18 items. And actually, every September, so pretty soon, I don't have the numbers yet, but pretty soon they will be releasing 2024 numbers. So that enables the measurement of food insecurity and enables categorization of it. So different categories include marginal food security, low food security, and very low food security. And those are just research. The purposes of that is for research. And as I mentioned, it'll come out pretty soon. And I just wanted to share a slide to kind of help reader attendees kind of look at the statistics. So this is currently the most recent data that we have, I mentioned, is 2023. So you can see that all households, about 13.5% of all households had food insecurity in 2023, without children, 11.9%, and with children, 17.9%. So you can see higher in families that have children. Now, those households that have children, it's not necessarily the child that is experiencing the food insecurity. It's really any member of the household. And we know that parents often shield their children and will allow themselves to go hungry before they will let their child. So the childhood food insecurity is a little bit lower. You can also see that while food insecurity can occur in any zip code, as you can see on the map, there are certain areas of the country those who live in metropolitan and rural areas are more likely to experience food insecurity. But as food insecurity can be hidden, meaning somebody could have it and you wouldn't know it just by looking at them, even in affluent areas, some populations also experience food insecurity. And then I just want to show some trends as well. So you can see that food insecurity peaked back in 2010 or 2009, which is right after the recession. And it had been decreasing pretty well until you see this little spike in 2020. And this was obviously COVID. And then we had a lot of federal economic support, so it went down further. And then they took all of that support away. And now, unfortunately, the numbers are back up. And then I also wanted to highlight, just in thinking about families that may be experiencing food insecurity, it's more prevalent in houses with young children, so under the age of 5, single parents and caregivers, racial and ethnic minority individuals, those that have low incomes. I mentioned the rural and urban, and then from the map we saw Southern. So
Some staggering numbers, right?
unfortunately.
Yeah. So what are the downstream effects of food insecurity? And I guess specifically, I'm interested in learning about some of the adverse clinical outcomes since we have a clinician heavy audience today.
Yeah, and I will preface, I'm a pediatrician, so I focus a lot on kids, but I do recognize that food insecurity can span the life course. It starts really even in preconception. So even before I get to take care of the child, it actually starts in pregnancy. So we know that women who are individuals who are pregnant and have food insecurity are more likely to experience adverse perinatal outcomes, including low birth weight, higher rates of preterm, and just more stress in general and gestational weight gain. And then in children, we know that it can increase birth defects, have chronic conditions, including anemia and developmental delays and mental health concerns. And then in adults, it's associated with higher rates of chronic conditions, including depression and diabetes and obesity. We're not as sure. The connection between obesity and food insecurity is less clear for children than it is for adults. It's more correlated with poverty. So they haven't made that direct connection, but in adults, they've been able to make that connection a little bit more clear. And then older adults, are more limited in their activities of daily living, and they have lower nutrient intakes if they are experiencing food insecurity. So it really spans the life course, and it's something that we should, all be considering in our patients. And then specifically in children, children may not be able to voice kind of what they're experiencing, and sometimes it manifests in different ways. So physically, that they're going to have more poor overall health. They're going to be more likely to be hospitalized and visit, acute care settings, have lower dietary quality, even malnutrition and poor growth. And I mentioned the anemia. Mental wise, they can be acting up in class. I mean, imagine a child at school who didn't have breakfast because their parents couldn't afford it. I'm trying to concentrate at school and not being able to because all they can think about is that discomfort that they're feeling, that hunger, and that can manifest as behavioral problems, or it can manifest as academic problems when really it's just the child needs food. And then over here, also, I mentioned the developmental delays that it can be associated with. So, and then these can span, families go in and out of food insecurity. And so this can span the entire childhood and even have negative effects into adulthood.
So you mentioned earlier it's difficult to detect, right? You can't see food insecurity. So because it's so difficult to detect, right, we think of our audience here, we're celebrating Malnutrition Awareness Week, right? Malnutrition is something we can do a physical check on, and we have, some validated screening tools for that. So how should a provider screen their patient for food insecurity? What cues are we looking for? And I guess, how do you start that conversation? Sometimes I think that can be a bit difficult too, right?
Definitely. Yes, so I work with the American Academy of Pediatrics, and in 2015, which was way ahead of the time, way back then, the American Academy of Pediatrics published a seminal policy statement in which it recommended, and I'm not sure if your similar organization has those recommendations, but recommended routine screening for food insecurity in clinical settings. And I'm just going to share my screen, and that they recommended a two-item screener. It's called the Hunger Vital Sign, and it has two questions. Within the past 12 months, we worried whether our food would run out before we got more money to buy more. And within the last 12 months, the food we bought just didn't last and we didn't have money to get more. So those two questions were recommended to be asked. They come from the household food security scale that I mentioned earlier that the USDA uses annually. But remember, it's 18 items. And so that can be very tedious to answer in clinical settings. These are two questions lifted from that questionnaire. They really take 2 minutes to answer. They are validated by the Children's Health Watch. And they've been incorporated into multiple clinical settings. The AAP policy statement recommended, I think, unknowingly recommended answer choices that were dichotomous. So the answers to those questions, yes or no. But we know that when you use research has shown, and I have the citation down below, that if you use those the dichotomous variable answer choices, then that can miss almost 25% of at-risk families. And so with this new policy statement that I will be the lead author on, if I can ever get my act together, we recommend using the Likert scale, which has the answer choices of often, sometimes, never, refused, and didn't answer. That you can see they also did the study also looked at the 30-day asking these questions and the 30-day time frame versus the 12-month time frame. And you can see that the 30 and the 12-month are just as sensitive and a little bit less specific, and up here more specific with the dichotomous. But we really want sensitivity. We want to pick people. We want to get people who have food insecurity and who will answer yes to these questions. So a yes to either one of these questions, I forgot to mention, means that the family has food insecurity. So if they say no to one and they say yes to the other one, it's still considered a positive screen. And so what we really recommend is using this hunger vital sign. These two questions really takes 2 minutes, and to use the 12-month because it's very sensitive. When thinking about screening, implementing screening, it's important to think about the modality because and how you're going to screen patients. So you talked about like how do you start that conversation. We did find there's 2 studies. Both of them found that written or electronic versions of screening were more likely to elicit a positive response that was statistically significant. And so the thought behind that is that when verbally speaking to families and patients, there's that stigma that's associated with food insecurity. So they're more likely to say yes on a paper than yes in person, than yes when verbally. And so if you do screen, we do recommend paper or electronic version. And you had asked, like, what is the best way, to start that conversation? And I'm going to unshare here so we can talk. So I mentioned because there is that shame that's associated with food insecurity, it's helpful to preface any conversation that you have with really highlighting the importance, and I'm sure you do all the time, given the work that you do, that what an important role that food plays in health and how everyone should have an opportunity for health. It's also helpful to reassure your patients that you screen, and I would recommend universal screening because patients might be able to tell if you're sort of handpicking certain patients over the others. So we do recommend universal screening. And it's helpful to reassure them that this is a part of a standard of your practice, that you screen every patient for these questions. And then if you have parents of children and the children is in the room, sometimes parents feel less comfortable discussing that out loud with their child in the room. So you could consider stepping outside of that room or talking to them when the child is distracted. It may also be helpful to have just to let have visual cues in your practice as well. So posters for the federal nutrition programs, for example, can also help normalize the topic.
So we've screened our patient, right? And now we have a pause of the common interventions that we might see in the clinical setting at this point.
Sure. So I think there's a variety of interventions. I'm going to share my screen again. I think the most common one that people think of, and is because it's the easiest, is to have a list of resources. And that can be compiled fairly easily. Do recommend, if possible, identifying someone in the practice or wherever you are to be sort of that hunger champion. It's always helpful to have these resource lists that are local based. So, local food pantries, local anti-hunger organizations. We have an organization in Winston-Salem that delivers healthy meals to kids on the weekend. It's a local nonprofit because that's when they're not in school. And so getting to know those community organizations and what are around where your patients will be, I think is really important. But obviously it can be time consuming. Feeding America also is a great resource because they list all of their food pantries, and many food pantries are within their network. So that may be another place to start. It's helpful if you can list, hours of operation, location, things like that, just so patients can have that readily available. So having that hunger champion reach out and make those connections with community organizations, having that face. We have a patient navigator in my clinic that's been really helpful, and everybody knows her, and so they know how to reach her if they have questions, or if they have. We worked with the Foresight Backpack program, and they reached out to her because they knew her, and they were able to fund our food pantry in the clinic. So you make these connections, and you never know what can happen. So that's the most common, is a resource list. Unfortunately, it's actually the least effective intervention for food insecurity, although it is the easiest. Studies have found that patients, don't typically access those resources. There are online resource platforms like Find Help, for example, that can connect patients to these resources. But that's another way to help. I will share my screen. I want to mention food is medicine. So increasingly, clinicians are using these food insecurity interventions that are more, and that entail a little bit more, including medically tailored meal programs, medically tailored food packages, which are kind of like groceries, or a food pantry, basically, produce prescription programs, and government nutrition security programs. Those are things like the federal nutrition programs like WIC and SNAP. And then you have the population level. These are the policies, like the dietary guidelines for Americans. So those are some examples of the food is medicine pyramid. And so really the evidence-based interventions, these are the evidence-based interventions. They're not as strong in kids, so we haven't had as many studies in kids and randomized trials, but they are effective at improving health outcomes and reducing food insecurity. The most effective is there at the bottom of the pyramid, is the federal nutrition programs. Those are evidence-based, and these are just a few that I list here. But increasingly, providers are making direct connections with these federal nutrition programs from clinical settings, because we know that they are evidence-based and they're sustainable. A lot of times food pantries in clinical settings are grant funded because they're not quite supported by payers yet, which we hope that will come in the future. But these are just some of the examples of those federal nutrition programs that really, really work. And I'll stop sharing my screen.
Well, and I think, like, as I'm listening and tying this back to Malnutrition Awareness Week, I mean, this is so important, right? This is prevention at its finest, right? You screen for food insecurity. Food insecurity is something that can lead to risk for malnutrition or malnutrition itself. And so we've got to intervene quickly, get them connected with some community programs and some of these federal nutrition programs that you mentioned. I mean, there's so many resources, it looks like, available. We just have to screen for it, identify it, and then connect them. So last, I kind of just want to end our discussion today talking about, because we do have a clinician audience today, is what other resources do we have available for our clinicians who want to learn more about this topic?
Yeah, that's a great question. I think increasingly there are lots of resources in terms of learning about food insecurity. I think because it's starting to be, or at least it was, we don't know what will happen in the future, but sort of governmental systems like CMS, the Centers for Medicaid Services, was going to require screening for these social drivers of health. The JCO was going to require it in clinical settings. So a lot of these regulatory bodies were coming down with screening. So it's definitely on the horizon, and there's a lot more available. But I think to make it local, it takes a hunger champion to really find out what these resources are and make connections with them. Things that may be helpful, and again, I'm a pediatrician, obviously, but these resources I think work for anyone, even though they say pediatrician. But I really like this food insecurity toolkit for pediatric providers. Again, it's really very general, like all the things that I just said, which is identify a hunger champion, is on here, and that can apply to any practice. So I think it's a really great step-by-step guide that really starts off with, if you've never started even screening, it goes through the steps for screening, intervening, And then at the end, it's really great. It also gives case studies of like what different people are doing in different areas. And then it also, at the end, it recommends advocacy. So that's the other thing I was going to sort of highlight, especially now in this sort of, with the budget that was passed. I think that the federal nutrition programs are at risk, as is Medicaid. And so I think now is a really great time to lend your voice. You are a trusted voice because of your role. And so if you can do some outreach and some advocacy for the federal nutrition programs. This toolkit also talks through what are some ways that you can conduct advocacy that isn't just, reach out to your legislators, although that is one of them. So this is a really great resource that's available. It was published in 2021. So I always recommend it for families or for providers. And then I mentioned that increasingly providers are connecting patients with the federal nutrition programs. I have a very strong sort of affinity for WIC. I mean, all of them, but WIC. And so because we just know it's so good. And so I created a toolkit with FAAP and how kind of like what are the steps that you need to take in order to do direct connections from your practice to WIC. And so it gives a great step-by-step guide. And there are a variety of different ways that it can be done. We've done it here at Wake Forest, and we've been able to give WIC providers access to our electronic health record through a memorandum of agreement that we've had for a very long time because we have a shared patient population. And so we're able to send referrals through our electronic health record and they can access it on a weekly basis. That's one example. Some people have been using NowPow, for example, as another way. I think it may be named something different now. But this is just a really great toolkit. Again, it can be utilized by any healthcare provider or clinician to really, and similarly, the same steps that we can take for WIC, we can also do for SNAP. So you can take out the word WIC and put in SNAP, and it's sort of the same thing. So this, I think, is a great guide to sort of use and how to provide more evidence-based and sustainable interventions to patients who may be experiencing food insecurity or not, right? Even if they're just eligible for it, screening families who may be eligible, we know that, I forget the exact numbers, it varies by age, but a good quarter of the eligible population does not participate in WIC. And so that could be, another way that we make these connections. So just something to consider moving forward in your practices, connecting patients with the federal nutrition programs. So those are some good resources. I mentioned that we'll be publishing the new food security policy statement for pediatrics, but again, what can apply to pretty much any area pretty soon. So stay on the lookout for that. And these are my references in case anyone wants to access any of those resources.
That was such great information. I know myself, throughout visits myself, my children, right? I think I've heard some of these questions asked, but not in a consistent way. So I like that you've shared that with us today. Now, not to put you on the spot, but is there any data currently on what percentage of patients are being screened currently?
Oh, for food insecurity?
Mm-hmm.
Seriously? That's a good question. There's not a really good national study that I'm aware of because everybody's doing it differently, like even here at my health system. And I think only recently within the last, I think January was when the requirements were passed for hospitals to screen. And so I think everybody was rushing to figure out how to screen. And so I think we will have studies on that because of all these health organizations have been rushing to implement screening because it's now going to be required. But I don't have the numbers on how many are. Hopefully we'll have that, by the end of the year, and hopefully that sort of requirement doesn't go away.
Well, I do want to remind our audience that the Q&A portion is open at this point. So if you do have a question for Dr. Montez, you can put that in the Q&A box and we will do our best to answer your questions. Um, I guess, Dr. Montez, while we wait to see if some questions come in, is there anything that you really want to, like a final message? Like, what do you want to leave our audience with today on this topic? Is there a call to action today, right, for them to kind of go back to their practices and make a change?
Yeah, sure. Well, I think as you saw on the trends slide, food insecurity prevalence is increasing, and with all of the cuts to the anti-poverty programs, we expect that food insecurity will continue to rise among families. And so I think if you aren't already, screening for food insecurity, to really consider it, even if it's just, you have a paper with those 2 questions, and you have a list of resources. That's a start. I do want to say, however, that screening for the sake of screening can be harmful. It can also result in distrust with the families if you screen and they say yes, but you have nothing to give them. So I will caution that please have a plan to address a positive screen in a culturally effective as culturally effective way as possible, so that you don't cause distrust with the families. But yes, so if you're not screening, to already screen and provide an intervention. Community partners are wonderful. You'd be surprised. I mean, they do this work on a daily basis, and so they usually are hungry to work with providers and make those connections. We have relationships with our local county, both WIC and SNAP, and we love them and they love us, and we're just so excited, and it's so wonderful. We actually have a SNAP worker on site at our children's hospital and our outpatient clinic, helping us enroll families, and that's like a novel concept, but they were very excited to do it, and they're actually writing it up for one of their conferences. So yeah, I think community partners really do want to partner. So identify that hunger champion, figure out what your resources are in the community, meet with your community partners, and start today.
Thank you so much. This will now conclude our session today. So thank you all for participating in today's program. Thank you again, Dr. Montez, for your wonderful presentation. A special thank you to ByHeart for supporting this program as well. So have a great day, everyone.